Good afternoon, Dr. Williams. I'm Soo-yeon from KMCRIC, Korean Medicine Convergence Research Information Center. Thank you for joining us on this interview.
You're welcome.
I'd like to start the interview with this question. For the audience who might not be familiar with your work, could you briefly introduce your work, your research, please?
Yes, thank you. I'm very interested in how people express pain in their behaviour, and there are two main areas apart from speaking about pain. And one is the face, and then there are all sorts of behaviours in the body. The face is particularly interesting because we express our emotions in our face, and we also have an expression for pain, and that expression is absolutely specific. So it only occurs with pain, and you can see it right from even premature infants right through to elderly people, even into dementia. And that's what's so interesting clinically, because it's going to allow us to understand better the pain of premature and small babies who often have quite painful procedures done to them, like taking blood. And we need to know about their pain so we can relieve it. Also with the many elderly people who often have painful disorders, and yet as they become demented they're much less likely to tell us about their pain. The same is true of anyone with a cognitive impairment. And even now there are studies in people who are unconscious and who still, when they're moved or blood is taken, show a little facial expression of pain. So we perhaps should be giving analgesia even to unconscious people to try to prevent a pain memory developing, which then may cause problems when they come round. So there are many clinical applications of understanding the face. The body, there are no specific behaviours. We all assume it's pain if we see someone rubbing or limping, but it could be for other reasons. So those behaviours are harder to understand, and they may be more related to anxiety about causing further damage than a direct measure of pain. But that's still speculation.
I see. So mainly in the pain expression of patients in the facial and behavior. So you just talked about like infants and elders who cannot speak of their pains exactly. So basically we have to kind of estimate their pain.
Exactly.
And estimating another's pain, it's like tomorrow's workshop's title. Can we get it right really? What's the biggest challenge there when we have to estimate others' pain?
Well, we're better at estimating someone else's pain if they are like us, ethnically, gender, age, and so on. We're not so good across differences, and yet, as you know, in medicine our patients are often very different from us, and we need to understand their needs just as well as our own people. So it's often things in the person who is doing the estimating of pain. We know that in healthcare professionals as well, there are certain beliefs. Some healthcare professionals believe that many people exaggerate their pain, either to get drugs or to get sympathy or to get a time in hospital or whatever. And those who really think a lot of patients exaggerate tend to downgrade their estimation of everybody's pain. So it isn't that they are good at identifying people who do exaggerate, they just discount everyone's pain by a certain amount. And that can mean that they really underestimate how bad pain is. So whether the person can tell them or not, they downgrade it. And we see this tendency more the longer someone's been in practice. So that can be quite a problem. The most experienced doctors can be most sceptical about others' pain. And we need to counter that scepticism and get accurate understanding of the pain face.
I see. I have another question here. So pain, it's such a subjective phenomenon that patients report. We just merely estimate, like we're talking right now. And in the research of chronic pain researches using complex interventions, we're kind of in need for valid and reliable outcome measures for the pain. So would you have a recommendation for such research?
Well, I think one needs to go back to why one's trying to treat the pain. And of course the best thing is always to get rid of the pain and then assume that life will go back to normal quite quickly. But we know that a lot of pain can't be relieved, and even in some patients when it is relieved, they're so worried that it's going to happen again that they may not go back to their normal activities because they worry it will provoke it. Headache's a good example. Some people avoid bright light even though they hardly have a headache, but they think because they avoid bright light that's why they don't have a headache. So that's quite disabling. So I think we need to broaden out our outcome measures, so not just pain but sleep if they're having sleep problems, mood if the pain distresses them, anxiety about the pain and the impact, and quality of life, activity, things that happen for them in the real world, because if they're going to have to live with pain, then what matters is that they live a life that they enjoy, spending time with their families rather than having to go and lie down separately, being able to go to theatre and cinema and music and art and just out and about, enjoying being with other people and not being isolated. There aren't perfect measures of that. All the quality of life measures measure slightly different things. The American ones are full of driving as quality of life. Some people don't drive but have good quality of life, so it might be more about being able to play with children or grandchildren or care for one's family members or enjoy cooking or do a sport. It can be lots of things, and I think we need to routinely include those in our outcomes, because quite often even just making the pain a little bit better makes someone able to do those things. So the pain relief might not be great, but they're freed to start to do things.
That's a very good point. Thank you very much. Here is the last question. It's for the future students who are interested in your group. Could you tell us what kind of qualities you look for when you're interviewing the candidate students?
I guess I look for a real curiosity about pain and compassion for it too, because they're not always easy patients to work with, and one needs to really feel for their difficulties, even if one finds them hard to work with in the immediate term. And I think students have to accept that the more they put in, the more they will gain. So if they have other commitments in their lives, like children and so on, that can be fine as long as they know how to balance them. I would never want to discriminate against anyone for having children or being a carer perhaps of a parent, but they need at least to be able to think about and discuss the demands, because as you see here, you could spend years reading everything that's here in just a few days, and there's always more to read, more to do. They need to be able to balance.
I see. Well, thank you so much for sharing your study and your story here.